Great. So, hi everybody, it's Sean Levis. I'm one of the three co-leads of RISE. We're delighted to welcome you back to our first post-Wave 1 COVID webinar. And this is our chance to introduce the OHT Central Program of Support. So I'll just be acting as a bit of an MC for the discussion. There's a few slides specific to RISE, but we're going to be hearing from all of our collaborators across the OHT Central Program of Supports, as well as from Alison Costello, who all of you know as the lead within the Ministry for OHTs. So as I'm sure you've heard before, the OHT Central Program of Supports has been designed to help OHTs make progress, and we think of it as making progress in two distinct areas. One is using a population health management approach to move the needle on quadruple-aim metrics for their priority populations, and the second area that we're hoping to support you in making progress is putting in place the 8 Ontario Health Team building blocks. So today's webinar is a chance for you to hear directly from Central Program of Support partners about three things. One is the alignment of these supports to a population health management approach and the OHT building blocks. And I'm just going to use the next few slides just to give you my sense, the 30,000-foot view of how these supports map to those two areas. Then, where applicable, a sequencing of the supports by cohort. So when I later put on my RISE hat and introduce some of the supports that we have coming online this month, you'll see that I'm sometimes talking about things that we'll initially be doing with what we call cohort 1, the teams that were approved a while back, and then cohort 2, the ones that have been approved much more recently. And in many of our cases, we'll also be helping you understand how to access supports. Based on today's webinar, we'll be creating a web page on the RISE website that will allow you to easily navigate to find exactly who you should be in touch with for what kinds of support going forward. So just these two slides that I mentioned, one is aligning the supports for population health management. So for those of you who are part of cohort 1, you'll have seen these steps in a population health management approach before, and hopefully you'll have seen Rob Reed's presentations. RISE is working at all of these levels with the particular leadership of Rob Reed, one of my co-leads who has a lot of experience with population health management. But in addition to RISE, there are key partners in the Central Program of Supports that have particularly rich expertise in some of these other areas. So I haven't run my take on this past all of them, but I see Walter and Ruth from the Health System Performance Network doing great work on population segmentation. They're obviously also critical in that last row with monitoring reach and other process measures and evaluating quadruple-aim metrics. Tupper, who you'll be hearing with shortly, their center, the Center for Effective Practice, has done a lot of work with guidelines and so on, especially in primary care. And as many of you know, we have brought in many health system partners to contribute to each of the collaboratives, one for each priority population. So if we're talking about people who would benefit from a palliative care approach, we've linked to the appropriate experts across the province and sometimes nationally and internationally to support that co-design work for each population segment. And then you'll be hearing from Michael Schul and Minnie, who come in as with some of the others really helpfully on that evaluation piece. So if we move to the next slide, so moving from population health, moving from population health management to the OHT building blocks. So the first column are the OHT building blocks. So with the ministry's work over the last couple of years, these were originally called readiness criteria, but most of us now call them the 8 OHT building blocks. Some of the most direct alignments that I think are important for you to know is you can all benefit from the expertise of Julia Abelson and her colleagues with the Public and Patient Engagement Collaborative supporting the building block related to patient partnership, part of building block 3. I put collab period just to remind myself that we're going to be using collaborative in a different sense than it's being used here when I come to the RISE slide. So just keep in mind, Julia's collaborative is more of a research collaborative, and the collaboratives we're going to be talking about are learning and improvement collaboratives specifically focused on OHTs. So just slightly different uses of the same term. With patient care and experience, which is where the population health management stuff fits in terms of the building block architecture. HSPN, as I mentioned before, fits in directly there, and they have guides available specifically related to population health management. For digital health, we have the Digital Health Secretariat, part of the Ministry of Health, providing expertise. For leadership, accountability, and governance, many of the Cohort 1 OHTs will have been able to benefit from all of the work being done by Ross and his colleagues with the Advanced program. And then moving down into performance measurement, QI, and continuous learning, we benefit from two of the groups I've already spoken about, HSPN and ICES, who you'll be hearing from, but also Mike Green, and I don't think Rick is joining us today, but his co-lead Rick Glazier, who for anything related to primary care can be helping in this space with Inspire PhD. And then Tupper, who I mentioned on the previous slide, also comes in this front. So this is my perhaps unique window onto this, the 30,000 view about how we have these tremendous partners that add particular value either to different steps in population health management or to the building blocks. And I recognize that many of them have expertise that fits into other areas, but this is kind of my elevator story about how to make the tightest connection between steps in population health management and building blocks. In addition to the OHT Central Program of Support Partners, there are an array of other health system partners, the Change Foundation, the Ontario Medical Association, many others who obviously also bring critically important expertise to the work of OHTs, but today's webinar, we're focusing on the members of the OHT Central Program of Supports. So that's a quick whirlwind introduction. I'll turn it over now to Alison Costello from the ministry for a couple of comments from the ministry perspective. So Alison, over to you.
Thanks so much, John, and great to see so many participants across all of the teams on the line today. I just wanted to take a few minutes to talk about, the ministry's interest in organizing these supports. We, of course, committed to doing so in our guidance document from almost 2 years ago now. At that point in time had kind of predicted what we might need to support OHTs. And I think a reflection that we have and the partners on the line, I'm sure would share, is that we will continuously be learning what you will need to go forward. We want to make sure that everything that we are offering is done in a spirit of continuous improvement, and the learning we can gain from you all, and as you're evolving and growing and improving on the work that you're doing, that we are understanding what those evolving needs might require. So we're, the Central Program of Supports, as John's referred to it, is the partnerships that you'll hear from today. And we work together to coordinate activities as best we can. We want to make sure that we're delivering available supports through various modalities so that can be responsive to the readiness of the team, the time that you might have, what is most impactful for you when you need it. And of course, you'll hear as well about, Ontario has an incredible network of leadership in integrated care, and we've tapped into that across this network. And everybody has a really defined area of expertise, and our efforts are to make sure that we're coordinating those activities and delivering the supports that you most need. And the ministry has our points of contact that are available for teams to be able to help triage or point you to what might be available. But we additionally have direct connection points to a number of the partners on the line today. So we just wanted to, insert ourselves into this presentation today to indicate that it is the ministry's strong commitment to support OHTs along this path. And we will be working to really make sure that we're hearing from you about what you need next, what you need more of. And it is large to be able to support you all in those efforts, but we really do want to maintain that close feedback loop and, looking along the horizon to what might be needed next so we can start to grow that as the work is underway. So thank you to John and team for organizing this today, and happy to hear the discussion.
Thanks very much, Allison. And keep in mind, folks, that you're welcome to post. I think you can post in either the chat box but especially the Q&A box, so that we can have questions in the queue when we've had a chance to go through the presentation. So we're now going to have some kind of short snapper presentations by different groups. I'm just getting myself out of the way at the beginning, and then I'll pass it on to colleagues. Ross Baker will be up next. So just a few words about RISE. I'll skip to the mission. Our aim is to provide timely and responsive access to Ontario-based rapid learning and improvement assets. So there are times where we're leading supports, other times we're enabling the work of others, and other times we're playing a bit of a traffic cop role and making connections between OHTs and other players in the system who can add value. I'm going to go into the first program objective in more detail on the next slide. It's the area that we've been working on a lot from a design perspective while our formal work with OHTs was put on pause during wave one, and we're very soon going to be announcing a lot of these supports that are coming online, coaching, collaboratives, and communities of practice. The latter two exist, but haven't been as actively engaged yet, and that's about to ramp up. Many of you will be familiar with the activities and products that we do. We recently had a RISE Jamboree on primary care engagement with the Center for Effective Practice. We've updated our RISE briefs on population health management for priority populations. We've produced a RISE rapid synthesis on lessons learned about integrated care during COVID. So all of that sitting on our website, and then we also share tools and resources with OHTs. So our website is meant to be kind of a one-stop shop for OHTs, not just for RISE produced material, but for materials and events being organized by OHT Central Program Support Partners, as well as other health system partners. We have webinars like today's, but we have two coming up that we'll talk about at the end of the webinar to help with onboarding cohort 2. We have monthly newsletters, so if you haven't signed up to it, please do. And then we have a Twitter feed. But I just want to expand on that first point about supporting rapid learning and improvement. So we'll soon be announcing a set of coaches for population health management. There will be one coach for every 5 to 6 cohort 1 OHTs. They will have the initial access to the coaches. We anticipate cohort 2 will start to get connected with their coaches starting in June. We think that the ideal target audience for a coach in an OHT is the OHT's overall lead for population health management. We recognize most OHTs have an incredibly small secretariat, so this might be the head of the OHT. We'll leave it to your discretion. And some OHTs have both a clinical and an operational lead for their priority population working groups. They might call them different things. And others might have a slightly different leadership structure, but those people who are championing that effort to move the needle for priority populations are the targets for this coaching. The coaches can play many roles. They'll be a facilitator, so you'll have someone who, as your needs for different supports emerge, can say, oh, we'll just pull in this resource that we know is available. And we hope it'll make it easier for you then to not have to understand the full complexity of the support. The coaches can help you in that individualized way. They'll also be a mentor for things like change management and a more narrowly defined coach. So this is different from the coaching Ross and his colleagues are providing, which is focused more on collaborative leadership. This is coaching for population health management. That'll be complemented by the collaboratives for population health management. So these exist on Quorum, the online interface, but we're going to start to really connect with them. These are more time-limited, goal-directed groups. They'll be supported by the coaches. And while they're open to all, so cohort 2 is welcome to actively participate. Initially, more of the focus is likely to be relevant to cohort 1. And you'll see the plan for roughly 1 to 1.5 hour meetings every month, combination of sharing new content, you sharing with others, open dialogue, ideally a commitment to action, and between meeting action plans. And then the communities of practice, in comparison, are more open-ended and member-driven. They're open to all. Our 3 most active ones focus on building block 3, patient partnership, digital health, building block 5, and performance measurement and improvement. And then the final slide is just to help you navigate RISE. Anytime you have a question, feel free to send us an email at rise@mcmaster.ca. We've now aligned our focal points to the same regions that Ontario Health uses. Our coaches will also be aligned to regions. So if you're in the east and north, Anna will be your focal point. In Toronto or west, Carrie, and for central, Leslie. Our website, as I mentioned before, has everything that we have been able to find and will continue to find relevant to OHTs. And if you haven't signed up for the Collaboratives and Community of Practice, you can go to the Quorum link, which has been maintained by HQO, now Ontario Health, for some time. So that's a quick run through with RISE. Ross, I think we're over to you now with an update about Advance. I can see both Ross and Paula. The mute button should be at the bottom of your screen.
Okay.
The mute button. There we go. Yep.
Sorry. Thanks, John. Ross Baker from the University of Toronto. I'm working with Paula Blackstein-Hirsch, Heather Graham, Michelle Nelson, Andrew Pinto on this advanced program, which is focused on shared leadership, governance, and accountability. We're just finishing the first round of our program with cohort 1, and it features 6 leadership workshop webinars, an hour and a half to 2 hours in length, on these issues, which we think are important issues in terms of the partners engaging in the OHT work, working effectively with each other. We've built this program on a framework called Collective Impact, the Collective Impact Framework, that was developed in the U.S. but has been used widely, not only in the U.S. but in Canada and elsewhere. And the Collective Impact Framework really works on 5 critical features to push forward these shared initiatives to focus on big, hairy, audacious issues like the one we're working on here for integrated care. The 5 features include creating a shared agenda among all members, working to create continuous communication both at the leadership level and the care delivery level, identifying and creating mutually reinforcing activities that support improvements for our target population, developing shared measurement, and then creating a backbone that provides supports to the leadership group and to the staff who are providing care. So I've given you a few sort of examples in the following slides that really talk about the advanced program, and starting with that first slide, just to give you some idea of the kinds of issues that we're talking about. This is from Module 5 on governance and backbone, which was delivered in the middle of November in 3 different sessions to our cohort 1 participants on this. And these sessions are interactive. They're providing an opportunity for us to point towards some useful information and resources, but then turning it over to OHT leadership groups to have discussions either at the OHT level or across OHTs to discuss the achievements and the challenges that they face moving forward. And this poll, or it's really a combined poll from the 3 sessions we did with cohort 1 on governance and backbone, issues for OHT leadership moving forward. And as you can see, about half the OHT groups are still saying they're working on these issues. They're trying to ensure that they can make progress on these issues, which are really fundamental to the development of effective OHTs. So the leadership councils on these groups are still working to develop the agenda, still working to develop the resources and the relationships that are necessary to move forward. Next slide, please. There's also a question about the relationship between leadership councils and the boards of provider organizations from which these partners come from. And in the discussion we had in the mid-November, we asked people on the calls to give us a sense of where boards were in terms of interacting with each other around this shared agenda and giving the necessary autonomy to their leaders to create and advance the activities that are necessary for integrated care. And as you can see, we're still at early stages in most of this work. Board-to-board interactions are focused mostly around information sharing rather than discussions on assets and gaps and future governance models. And then the next slide, please. The second part of our work really deals with the coaching academy, and the genesis of this idea is to provide some resources and some developmental activities for people who will work directly with OHT leadership councils to provide facilitation and support in dealing with these agendas that are being addressed by leadership councils. In the cohort 1 group, we now have 15 OHTs that have nominated a total of 34 coaches that will work with them on an ongoing basis. They've been interviewed by Michelle and others among our team to really understand what the issues are locally and to help to devise a curriculum that will be supportive of these individuals as they develop their coaching skills, they learn about the issues and challenges of OHTs, and then they work on helping their leadership councils to be more effective in terms of shared leadership, governance, and accountability. The last session that we do with the leadership group will be December 7th to 11th, where we'll help that group create specific OHT-specific roadmaps for the development of accountable leadership, shared governance, and related issues. And then we hand off to the coaches the opportunity to work with their leadership councils and to continue to have coaching development as they move forward. In addition to this, we have a series of evaluation activities, and we have ongoing work to develop some webinars on special topics. And our focus, as I mentioned before, is really working with leadership councils to provide them with some useful information and to help aid their discussions and their plans moving forward to create effective leadership groups that bring together those responsible for services in each community that has an OHT. Thanks, John.
Great. Thanks very much, Ross. Ruth, I think you're presenting for HSPN, so over to you.
Thank you, John. Congratulations to the next group of candidate OHTs. And next slide, please. I'm Ruth Hall, co-leading the central evaluation for the OHT initiative, along with Dr. Walter Wojcik and our team members here. You will be seeing us in various stages over the next couple of years. Next slide, please. So just a quick overview of what the central evaluation will look like. We know that because many of the OHTs they have various providers, priority populations, resources, and tools and approaches, that our evaluation must be flexible, and we also need to have evaluation happening locally. So we've finished phase 1 with the first cohort in their formative evaluation, and we're going to be moving into phase 2 with the first cohort in what we're calling the developmental evaluation, which is really focusing on that quadruple-aim evaluation framework, and working with you in a formative evaluation to look at your readiness for implementing the integrated care for your priority population. Next slide. So how will Health Services Performance Network and the central evaluation support you? Through looking at the building block structure. For defined population, we have done a document analysis of the first cohort, and that is available on our website, and that's identified the most prevalent priority populations that were selected. And in the new year, you will see more work about this population health segmentation tools to help you get into better understanding about those priority populations. In building block 2, the in-scope services, we have the practice guides, again, available on our website. These are helpful resources to help you with implementation, focusing on different aspects of integrated care. Building block 3 with patient partnership and community engagement, that practice guide number 2 is very relevant to this building block. And you will also see that our document analysis of that first cohort, we've identified sort of the level of patient engagement and partnership that's happening in that first cohort. Next slide. And building block number 4 are patient care and experience. Again, those 2 key practice guides there, number 2 for patient and caregivers, and then a third one that is for providers that describes some activities that are necessary to achieve patient, family, and caregiver-centered care. We also will be launching a patient experience survey. It's one of the quadrants of the quadruple-aim that the OHTs will be asked to launch. And again, the population health segmentation tools are relevant to this, and that's forthcoming in the new year. In terms of leadership and accountability, building block number 6, there is, again, a practice guide relevant to that on the website, and our Organizing for OHT survey, we created reports on our website. There's a webinar that we hosted earlier in the fall, and this characterizes the strengths and limitations of the applicant OHTs across factors that are important for supporting implementation. And it identifies areas for improvement that are needed across the teams in integrating care. There's also the report that came out from an in-depth case studies that we conducted with 11 OHTs in that first cohort that pertains to several aspects, but leadership and accountability is one of the key ones. Next slide. And finally, building block 8 is where most of our emphasis will be in providing resources to the OHTs in the coming year. And it's really to support the establishment of measurement and management structures. So you will see on our website that there is a logic model development guide that is a very useful tool in thinking about how you are going to start planning and implementing your target population new way of delivering care. We also have had logic model webinars that are again available on the website for your viewing as well. And early in the new year, we're going to be releasing or giving webinars and sharing with everyone the indicators we're thinking about for OHTs in general about integrated care, and then specific indicators relevant to the mental health and addictions priority populations, palliative end-of-life populations, and the frail and older adult populations, as they were the most dominant priority populations identified. Next slide, please. Just a key date to remember, December 10th, please. I think you will have received some information from your ministry representative about getting contact information so that we can send out our surveys to you to look at your early stages of coming together as a team and organizing to plan for integrated patient-centered care. And please send that to us by December 10th. And lastly, everyone's involved in the evaluation. Follow us on Twitter. We can be reached through email at our email address. And please go to our webpage and subscribe to stay informed. Thank you.
Great. Thanks very much, Ruth. I think we're now moving to 2 in a row focused on primary care. So first we'll hear from Mike Green from Inspire PHC.
So hi, everybody. Mike Green from Queen's University. I'm here in my role as co-lead with Rick Glazier for the Inspire Primary Healthcare group, which is a research and policy partnership really focused on primary healthcare. And our focus within the OHTs will be on supporting primary care-related aspects of the work that needs to be undertaken. Super important with the reach of primary care into the entire attributed population. Can I have the next slide, please? Or can I advance it?
It's moved ahead, Mike. It's on slide 2.
Perfect. Okay. So our role is to provide some data specifically on primary care. We know that taking care of patients, particularly those that may not have good access to primary care, currently is an issue. So we're looking at that. We're looking at how digital tools like eConsult can be integrated into care pathways in order to support integration of care between specialty and primary care sectors. We have a new piece of our organization, which is an Oracle, which is an Ontario-wide network of primary care practice-based learning networks that can support and work with OHTs in their area on projects that require access to data from the electronic medical records and how to integrate those. We have been working with work led out of Western by Judy Brown on physician engagement, in particular primary care physician engagement within the Ontario Health teams, and also with some of the challenges and work that are being done in terms of integrating primary care providers into networks or alliances or councils, whatever they're being called in your local area. And finally, we also have some research projects that have developed important information about how to help connect people in the community to community sector resources through their primary care settings and on engaging patients within the primary care environment. Take the next slide. So what can we offer more practically? So we have what's called an Applied Health Research Question Program, and Ontario Health Team requests for support for additional data or questions that they have about how to support the projects that they're taking on locally are something that can be submitted to us for consideration, and if it's something we're able to assist with, we can do some OHT-specific work to support those projects. We're providing a general additional data on primary care and how it's delivered and organized in the regions to the candidate teams. That'll probably be available early in the new year once we have all the updated attributable population data available to us at ICES. Groups like the one here in my own local region here in Frontenac, Lennox, and Addington region are interested in providing care to patients in their population who don't have good primary care, and we have some detailed information on who those patients are in your region and some more detailed descriptions about their characteristics, whether they are maybe someone who's a part of your priority population for your year one. And we're also able to provide then some guidance on engaging primary care providers and supporting effective primary care relationships within the OHT. So in these areas, we kind of supplement the work that some of the other groups might be providing on governance and engagement, say at the full OHT level, but it also has to happen in primary care. So this would complement the work being done by the advanced team, and similarly in terms of QI and evaluation support for more specific measurement or metrics around those primary care specific elements to complement the work being done by Walter and the team at HSPRN. So I'm going to end there and pass off to Tupper, I believe.
That's great, Mike. Thanks very much. Your ability there at the end to link this to the other pieces and make the connection to primary care was fantastic. So we're going to stay with primary care now. Tupper, over to you at the Center for Effective Practice.
Hi, thanks, John. Can you hear me?
Yep, absolutely.
Great. Okay. Hi, everybody, and thanks for having us here. It's exciting to be talking about these topics. And as I'm sure you're aware, all of us have been thinking about this world and this new world that we're going to be moving into and are moving into right now. But I want to preface the work of my presentation with really saying that we don't have all the answers, and we are looking forward to talking with anyone who wants to talk with us about how to do this better and what your thoughts are and how we can work with you to help you achieve success. So I will just give an introduction to you about the Center for Effective Practice. We're an independent not-for-profit that's been around for about 15 years, and we focus really on primary care clinicians, mainly nurse practitioners and primary care physicians, family physicians, but we do often that audience bleeds into other areas, and we do end up doing a lot of community-based engagement with other providers too. I've tried to think about how what we do can help OHTs, and I would say the biggest thing I'd like you to think about is that we are I'll say, core business and focus as an organization is on the implementation of clinical evidence into practice. So when we talk about engagement with providers, really, I think if we can boil it down for us, it's really about getting providers to do something differently at the practice level that is evidence-based or better for your OHT or whatever. And the real question is, how do we understand and influence these providers in the field across your OHT and across the province for that matter to do things a bit differently and to be more aligned with other things that are happening in the region that they've practiced in and in the province generally. So there's three main elements that I think we can offer you as OHTs. The first is that we have a website that includes a number of clinical tools and knowledge products. They come in both sort of passive PDF type formats, but they're also increasingly EMR-based, HTML-based, et cetera. So we provide a number of ways for providers to actually access clinical information and tools and pathways. And that site right now is, for clinical information at least, the leading site in the province for both family physicians and nurse practitioners. And we've done a ton of work, as you can imagine, around COVID, which has been challenging, but it's also been an opportunity for us to expand our reach. And we have seen really, really strong increases in traffic based on some of the COVID work. And I would expect that to continue over into the OHT work and other types of topics that we'll be dealing with in the future. The second is that in addition to that site, which I consider a sort of system level, these tools are available for anyone in the province and are very important for consistency across practices and throughout the province. We also have what's sometimes referred to as boots on the ground. And we have 8 to, I think it's 12 pharmacists who are now in different regions in the province that are visiting family physicians. This is often called academic detailing or clinical outreach, but they're having one-on-one conversations with physicians and nurse practitioners occasionally around clinical care and around helping physicians not just understand the evidence, but implement new evidence in their practice. And so to give you a sense of the scale for that, we've now reached, I think, close to 1,000 family physicians. So that's 1,000 individuals that we've had one or more conversations with, clinical visits with, around topics like opioids and benzodiazepines, et cetera. So that's not just drugs, it's really around other topics as well. And the last piece I think that's important is that we have relationships, and I think this is something that you're all probably understand as well as anyone, that it's not just the materials you have and the content. Relationships are really important to help you both get the best services for your OHT, but also to disseminate and to have great uptake of those services and products that you're trying to offer your providers in the field. Next slide, please. I won't get into all these details, but back to what I was saying before, I think in terms of what we can offer you is, I think the relationship building piece is something that we work very hard on, and we're happy to work with you on as well. So how do we actually help you do this maybe better if you need some help in this area, or how can we leverage our own relationships to help you in your OHTs? That's something that we can certainly offer you. This notion of clinical effectiveness and appropriateness is really important to us. How do we help you understand the key elements and building blocks to do this well within your OHT? And how do we focus on implementation right from the beginning? I think John mentioned co-design, which is something that we've been doing for a while, and now people are really, I think, embracing that concept, which is really important. And I think it's really important to remember that the design element of whatever you're doing is tied incredibly closely to the implementation piece too. And if you can't co-design and design appropriate and well-designed resources, you're not going to have much success with implementation, for example. So all these pieces are tied together, and I'd like to think that we could offer supports in that area as well. And the last piece is around change management. And by that, I mean really getting detailed around what we're actually expecting providers to change, how we expect them to change, what's it going to take for that change to happen, the barriers and gaps in different clinical environments, whether it's team-based or solo. Those are the sorts of kind of detailed analysis that we do, and we'd be very happy to help you do or understand better in the future. Next slide, please.
Tupper, we're just over time. Would you be able to wrap up these last few quickly?
Sure.
Great.
Can you just, so go to the next slide, please. So what I will say is that we have a lot of the building blocks in place that might be helpful to OHTs. We have a number of topics that we've already covered that I think can be easily modified and could be applied to different either populations you're working on or as we mature the broader population in your OHT. And we are very much looking forward to working with you in the future. Next slide, please. You can certainly contact me later on if you want to follow up on this conversation at all. And thank you very much for your time.
That's great. Thanks very much, Tupper. So now we're going to switch to Julia Abelson talking about her work with public and patient engagement. So Julia, over to you.
Thanks very much. Can everyone hear me? Yes?
Yep.
Okay, great, because I had to be unmuted. Thank you. So really pleased to be part of this. I'll do a quick intro. First slide really captures me as lead of the Public and Patient Engagement Collaborative. As John said, this is more of a research collaborative. We have been around doing our work in this area for just under 10 years, focused on the role of patients and publics, broader publics in health system policy making and health research, with a specific focus on the evaluation of those efforts. So our role in the Central Program of Supports is obviously to support Building Block 3, focused on patient partnership and community engagement, with a particular focus on really working towards developing a stronger patient-centered health system, right? That focuses on supporting high-quality patient and community engagement programs, and as many of us do, have this lens of through continuous learning and evaluation. Next slide. And so what are we offering to you as OHTs? Very specifically, technical advice and support around patient engagement and partnership, but also in particular around its evaluation, whether that's more formative evaluation, kind of as you're moving along with your work to kind of evaluate in time, in real time, or more summative evaluation. On the patient engagement and partnership side, we work closely with RISE to support their work on Building Block 3, and will be involved in the Patient Engagement Partnership Collaborative and Community of Practice in this area. We're currently wrapping up a set of interviews with the first cohort of OHT patient partner leads that I think will inform some really important guidance that we provide in this area, which I think will be very relevant to the new cohort of OHT, so watch for that early in the new year. We also provide guidance on and appropriate supports for or approaches to thinking about how to evaluate engagement and partnership or potentially co-design, depending on the level of the maturity of your OHT. So we can advise very specifically on tools for evaluation, depending on where you're at, your maturity level, approaches to doing that. We can do that through individual consultations through AHRQs. Finally, we're leading a professional evaluation working group, which some of your patient partners are actually members of and contributing to, just met last week. This working group will be developing a resource to support the evaluation, in particular of impacts of patient engagement and partnership across the health system, including within OHTs. That's it for me. Thank you.
Great. Thanks very much, Julia. So we're going to go to Minnie, presenting on behalf of her and Michael from ICES. Minnie, over to you.
Thank you very much, John. Are you able to hear me all right?
Yes, absolutely.
Okay, perfect. Thank you so much. Thanks for inviting me today to speak to this group. I'm very pleased to be here. Next few minutes or so, I just wanted to give a snapshot of what ICES does and how we may support the OHTs. So I don't think that a lot of attendees on this call may be actually very familiar with ICES, so I just want to start by saying that we are an independent, not-for-profit research organization. We're now about 28 years young, and we really are comprised from a province-wide network of clinical, public health, and research experts. We use population-based health data to generate analysis and insights, really to inform decision and policymakers for the purpose of making an effective and efficient healthcare system and improving delivery. We are a steward of about 18 billion records for over 20 million Ontarians. This is growing by the day. So really this includes all health card holders, past and present. What this really means is that we are able to trace someone's trajectory through the healthcare system by linking together records from different sites and services. For example, if someone has been to their doctor, has been admitted to a hospital, has been prescribed certain drugs, or maybe certain lab tests have been prescribed to them, we are able to then link together all these pieces of information to really provide a sort of more wholesome picture of someone's encounters in the healthcare system. ICS is a key provider for the Ministry of Health and Long-Term Care Applied Health Research Question Program. Mike Green also did speak of this program as well, that his group, they also do provide this service. And really this is catered towards delivering reports and analytics to Ontario healthcare system stakeholders. It is part of our healthcare, part of our core funding, which means that these requests are performed at no charge to the requester. Next slide, please. So a little bit about our Applied Health Research Question, AHRQ. I'm focusing on this, I think, because for the purposes of the audience today, this is probably the most relevant piece of what we do. So ICS is considered a research provider, and what we do is we receive and adjudicate AHRQ requests from the broader healthcare system. And what we really aim to do is to use our data holdings to answer these questions that will help support policy and planning. Our knowledge users or requesters include policy development staff, planners, decision makers from across the Ontario healthcare system, including but not limited to the ministries, the Ontario health teams, hospitals and institutions, Indigenous communities, provincial associations and agencies. Depending on the nature of the request that comes in, we have sort of 3 tiers of responses that range from really 5 business days to over 8 weeks in terms of delivery time. I have included the link to our webpage, so I really do encourage the attendees to check it out. There's a lot more information there as well for you to kind of look through. Next slide, please. And so what does this mean to me as an OHT? I would say that ICS primarily provides support as sort of the bookends of the OHT building block, so mostly involved in the first building block and helping define a patient population, in addition to the 8th block, which really involves performance measurement, quality improvement, and continuous learning. I do really want to emphasize that, you know, we don't operate in a vacuum, and we have very close and continuous engagement with the Ministry of Health and other organizations and key stakeholders within the OHT Central Program of Supports. And we really do this to, in our efforts to maximize the alignment of the supports that we provide, and also to avoid duplication, especially from the data and analytics perspective. I would say primarily that up until this point, a lot of our support really has been focused on building block number 1. And I have included a few examples of AHRQs that we have completed to date that are related to OHTs. So as you'll notice, you know, it's information that we've provided about certain populations for the purpose of guiding health services planning. We've also helped certain teams sort of support their application in trying to figure out who is part of who they would like to be part of their OHT. And as well, we have provided information to an additional group that really is trying to figure out, you know, accessible physical and virtual points of contact to their population. And following this, evidence will be evaluated to assess the baseline understanding of the patient experiences as they relate to this access. I've also included another link to our website where it really outlines all our completed projects to date. So while it may not be specific to OHT requests, it will have other requests that maybe help trigger or make you think about how we may help you. And finally, you know, we really encourage you to contact us. We're happy to have a conversation and consultation with you just to see how we may be able to be supportive of you on your journey. Thank you very much.
That's great. Thanks very much, Minnie. And I now seem to have access to send in the Q&A box, so I'll see if this is working. But Declan had asked, are collaboratives for population health management open for OHTs who are in development? So when I scroll down, did my comment come through? Maybe not. So my answer was that the collaboratives that are focused on the priority populations are going to be particularly relevant for teams that are actively putting in place population health management for priority populations and that can commit to action between meetings to really implement what they're learning from one another, from the coaches and from the presentations that will be made at the monthly sessions. So it's probably going to be most relevant initially for cohort 1, over time cohort 2. That said, we're not going to restrict entry. So if there were other teams that wanted to listen in anticipation of getting to that stage, then that's certainly fine. The communities in practice are more clearly open to everybody and much more member-driven, and so teams in development might want to lead conversations on particular topics in the communities of practice, and we'd strongly encourage you to do that. Abigail had a question which maybe is best directed to Ruth. Allison may want to weigh in as well. The question is, how do the indicators being released by HSPN in January 2021 relate to the previous HQO/Ontario Health Quality Improvement Plan indicators? So Ruth or Allison, would either of you be willing to respond to that?
I can take a first stab, and Allison, if you want to build on that. We are making every effort to make sure there's alignment. We don't want to have extra work required, multiple indicators having to be done for multiple parties. I will say, though, that the HSPN will be calculating the indicators that we will be, for all the OHTs, so there will be no work on their part, and they are predominantly from administrative data.
Okay. Allison, would you add anything?
I don't think I would add anything, but I might just add a wrinkle, which is that in addition to what might have previously been shared through OHTQO for QIP across many sectors, the ministry additionally has asked the first cohort of teams to confirm 3 indicators that would be part of their initial TP and build to an eventual collaborative QIP. So I think we're pursuing alignment across all those fronts. Yeah, I would just say that we're working to make sure there is alignment, but there are a few different moving targets on that front.
Great. Thanks very much, Allison. Then Veronica Nelson wrote, as a rural community, we've engaged primary care and our specialists. Can you direct me where to find information relevant to specialists other than the OMA? So Veronica is obviously aware of the work they're doing. Veronica, in the chat box, I provided a link to a resource about engaging both primary care physicians and specialists in accountable care organizations in the U.S., and OHTs share many design features with those, so that hyperlink may be relevant. Mike Green, Tupper Bean, anybody else on the line, would you point to other resources? I know both of you are focused more on primary care, but could you point, Veronica, to anything for specialists?
I'm thinking, I don't know if the Royal College, Mike, would have any resources for an OHT.
And we can certainly commit to, of course, look into this, and then we'll post stuff on the RISE website. But Mike, were you going to jump in?
Yeah, I was going to say the OMA really has been doing more of the work around general engagement with physicians and has some good ideas. The other group that might be able to help people would be some of the bigger academic centers have kind of large specialist organizations in the academic APPs, and so they may also have some ideas about kind of organizing larger groups of specialists into kind of collective group.
Okay, thanks. So now just moving a little bit further down, Tori has 2 posts. One I think was directed at Tupper. Great to hear about this clinical detailing outreach to primary care. So thank you, Tupper, for that. And then Tori also writes, any guidance or best practices for engaging with people with lived experience or homeless populations in co-design? And that is not the question that Mike Green answered in the chat box. That's a different one. Okay. So Julia, do you want to weigh in on this with the patient partnership piece of co-design? Or Ruth? Ruth, you mentioned you have resources for co-design. I don't know if you've ever worked specifically with homeless populations in these co-design processes and whether your materials speak to that particular population.
We haven't worked with that particular group in the co-design for patient experience. And I do not believe that the practice guide really focuses on particular groups.
Okay. Julia, would you add anything? Could you think of any relevant resources?
John, Steve is just going to unmute her. We had trouble adding her
panel. Okay. Okay.
Maybe while we're attempting to unmute Julia, I think on the whole, I would say the types of questions that we want, that we're seeing in the chat, we would really want to kind of support more knowledge sharing. So, Tori, I think we've heard from some teams recently that have a particular focus on homelessness. I think that there could be a lot of benefit in teams sharing across each other and learning from each other about best practices. So I think we consistently and constantly want to hear about what people are interested in hearing from each other. But I do think that we have a pretty good sense on what that can look like. But I think anytime you guys can give us that feedback on what we can kind of organize across teams that might be encountering similar challenges or working with unique populations that may not be the experience across every OHT, we would really want to kind of jump in and be able to support that connectivity.
Great. And Mike, could you speak to your comment in the chat box? Maybe you are referring to this particular question. You said the data packages could provide the numbers, so maybe you mean the numbers of homeless people and which OHTs they're attributed to.
I was answering a question from Tori Merritt about people who may be in your geographic area but are attributed to an OHT somewhere else. In terms of maybe being, particularly in some areas that may represent just differences in affiliation or people who have difficulty getting care locally.
Okay, thanks very much, Mike. And it feels like some people aren't seeing the questions at all. Others, it seems like, are seeing slightly different ones. So if I'm missing any, it would be good, Carrie, if you could weigh in. Tupper has added in the chat box, local hospitals might be able to help with rural specialist mapping / engagement. And Julia, I think you might now be unmuted. Would you be willing to weigh in?
Yeah, I am unmuted, but I unfortunately can't see that question, but I'm just picking up. I mean, I think the comment that was made about just being aware of these requests and the areas of particular interest. So this is around the engagement with homeless populations. I mean, this would be something that I'd have to do a particular search for, to be honest, because I'm not sure that the co-design, engagement partnering kinds of models that I would be familiar with, I would have seen them used in this particular population context, right? Really unique population context. So this would be where I'd need to be thinking about tailoring and learning more about how best to help out on that particular request. So.
Absolutely. And Tori's saying thank you, and would be great to get connected to other OHTs also focusing on people experiencing homelessness populations. So I agree very much. And as you heard us say, we're now aligning our focal points with the Ontario health focal points. Our coaches will be similarly aligned by region, and those coaches and the focal points we think will be really helpful in when questions like this come in to quickly identify other OHTs that might have relevant experience and then do that matchmaking so that you can be connected directly to people that might be one step ahead of you on one part of the work. There's also, someone has posted in the chat box some work being done by the Health Commons Solutions Lab related to co-designing with people who use substances, not the same population, but there may be shared approaches. So thanks, Anna. And Bruce has said, good idea to have sessions where OHTs can share how they're dealing with homelessness and in particular with mental health and addiction. So, and that would certainly, for the mental health and addictions piece, be a prime example of something that could be brought to the collaborative focused on the population and people with mental health and substance use problems. And Bruce also said COVID has raised the attention of this in the KFLA area. I better not take a guess at what KFLA stands for. So
Kingston, Frontenac, Lennox.
There we go. There we go. I went down a Kitchener hole and I couldn't solve it. Carrie, could you help me, or Steve? Are there any other questions that have come in? Oh, we're over time. So I think we have covered. Oh, there's lots of stuff going on in the chat box now. So there might be a few other things. So we will capture all of this, and we will make available the recording, and we will follow up on some of these very particular questions where people identified that we need to do a little bit more hunting, but this is exactly the type of thing that we want to be doing more of in the future. So I'll just turn it over to Allison for some final comments, but thank you everybody for joining us today. Thank you to the members of the OHT Central Program of Supports. It's great that everybody is back focused on this effort wholeheartedly. We recognize OHTs are struggling to varying degrees with COVID-19, but some of the work still continues, and as you grow in your ability to devote time to this, the central program will be there. And keep in mind that if you're part of cohort 2, that there are 2 upcoming webinars to try to bring you up to speed on some recent developments that cohort 1 would have been exposed to before. You can always go to the RISE website, and we'll be adding a page specifically on how to navigate the central program of supports, so that'll be available soon. Allison, do you want to say any closing words?
I'll just say very quickly, thank you to John and team for organizing this and all the members of the panel for walking through the information. We know this has been a bit of a fire hose for teams listening. We want to sort of take this next step together to be as communicative as possible in response to areas that you need resources or help or connection with. So, there's 2 webinars noted on this slide right now, but we want to kind of take the step beyond that to have more opportunities to share and talk and learn from each other, as well as leaders in the area. So thank you so much for joining in.
Okay, thanks very much, everybody. Sorry we went a few minutes over time. Thank you for your time, and have a good rest of the day. Bye-bye.